Good day. Welcome to the Health In Show, an affiliate program of Homeopathy World Community. This is Debby Bruck, your host, founder of Homeopathy World Community, and we are going to be speaking with Dr. Philip Hoekstra, who is the Chief Science Officer for Infrared Medical Solutions and a recognized authority in infrared mammography with 37 years of experience and 750,000 clinical patient analysis completed. He is board certified in neuroscience, oncology, and vascular thermology. Dr. Hoekstra is currently serving as president of the American Academy of Thermology and as director of the American Board of Thermology. We're going to be connecting with him via Skype, and we're going to be holding on the line. In the meantime, I'd like to also thank our producer, Amnon Nissan of Nissan Communications, for producing these shows and making them so wonderful for everybody to join us, whether you're coming in through Skype, through Facebook, wherever you're getting these messages and sharing with your friends to learn about important health issues of our day. Now, thermography is thermology, thermography, thermoscan, however you say it, is the way that they detect cellular changes in the breast. And this is very important to me personally as a breast cancer survivor. I initially started with mammograms, and the time that I went for the new digital type of mammography, my breast was literally crushed. They not only asked for the typical number of scans, but they required me to come back and do more of them. I knew that it was damaging to my cellular tissue because I was black and blue. I was swollen and red. There was pain involved. I was unhappy, both physically and emotionally. That's when I started to investigate thermography. And so this is really, really important for women to know that this is available. I have up on Homeopathy World Community the announcement page with a lot of information about breast cancer itself, Breast Cancer Awareness Month, which is October each year. The number 1 in 8 women develop breast cancer in their lifetime. This number, I believe, is changing. It could be 1 in 7, which means if you have 7 women in a room, that at least one of you has been touched by this disease. There are ways to prevent it. Not what I consider mammography, even though we're told this is preventative. By the time they can detect any tumor, you're already in the disease. It is not what I consider preventative. I have a number of items listed for prevention. Reduce the coffee and caffeine from your diet. Are we able to connect?
Who told you he's not connected?
Oh, I didn't see it.
You are assuming things.
Okay. Dr. Hoekstra, I did not realize you were connected with us because I didn't see you. And now that I realize that you're with us, I apologize for taking up part of our precious time. We have an hour, and he is infrared. There we go. And I'm so happy you are with us. We are really, really honored to have you on our show today. So I was just listing a couple of items to remove and reduce coffee and caffeine from the diet, reduce sugar intake. It helps the cells to proliferate, eliminate red meat because of all of the chemicals and hormones, and we know estrogen is involved. Add seaweed to improve your thyroid, and the last is eating lots of cruciferous vegetables such as cabbage and broccoli. And I'm sure you're going to touch upon all that. And so we are ready to go with your presentation today. And I will take the comments in the chat as we hear them. If you want any interruptions, let us know. And I will let you know what the comments are asking or giving you information. Okay.
Very good.
Thank you so much.
Is my sound coming through well?
Excellent.
Oh, very good. Well, good morning, Debbie, and I'd like to convey my greetings to all the people watching and listening in. First off, this is a very important topic because I'm certain that everybody knows somebody who has dealt with breast cancer, if not themselves personally, a family member or a friend. And unfortunately, the story on that is generally not a good one, where somebody is found the disease late in the stages, and the typical treatment program has not done a very adequate job of dealing with the disease. So there's a great deal of anxiety, pain, disfigurement, and unfortunately too often death that accompany this. It's a very grave disease, I don't need to tell you. We are auspiciously in October, which is Breast Cancer Awareness Month. And this is really a October unlike many other Octobers because we're in the midst of a paradigm change. And a lot of things that have been institutionalized and held up as solutions in the past have basically been revealed not to be effective. And part of the talk I'm going to present is that in many ways the current paradigm has failed. Put in other terms, the emperor has no clothes. And I have a presentation that I'd like to run. Can we see that on the screen, the first slide?
It's up now.
I'm not seeing it.
Well, you might have to refresh your screen.
Wait
and
a
if
second. Wait.
if you
There we go.
Okay,
Yep.
great.
There we go. Excellent. I've got that up. And I've entitled this as to what every woman needs to know about breast cancer detection, because the topic is larger than diagnostic thermal imaging, which is my specialty. To begin with, as Debbie mentioned, I am the laboratory director of ThermoScan Reference Laboratory, and we are the largest provider of diagnostic infrared imaging in the world, with the experience of more than 40 years and more than 1 million patient studies. And I'd invite everybody listening to it their opportunity to look at our website, thermoscan.com, and we do have a continual flow of timely articles that come from friending us on Facebook as well. Now I've got a picture of me up on the screen, but I don't see my presentation. There we go. And the presentation looks a whole lot better than I do. Can we have the next slide?
Dr. Hoax, what you're seeing on your screen is what the audience is seeing.
Okay, very good.
So you will be all by yourself at one, sometimes we'll just switch back and forth.
That's fine. All right, let's go to the next slide, please. All right, let's start out with something very basic, and that is, what is breast cancer? And while there are 5 major classifications for breast cancer, something in the range of 85 to 90% of the breast cancers originate with the cells, a single layer of cells that line the ducts and the glands of the breasts. And these are called luminal type of cancers. And these basically break down into the ductal and the lobular variety of breast cancer. Now, if we can look at the cross-section of a duct, we can see that the single layer becomes thickened with abnormal cells progressively as we move from normal cells to a more advanced stage of what's called ductal carcinoma in situ, which is a precancerous condition. And this may further progress to become an invasive and malignant disease when these cells mutate further and begin to spread into other areas of the breast and finally further into other areas of the body. We have the next slide, please. All right. The causes of breast cancer. Well, again, the ductal and lobular tissues have a very rapid turnover and highly vulnerable to the effects of mutations. But the mutation is the operative word. The source of those mutations is multifactorial. And as Debbie indicated earlier, environmental conditions are the most important thing for developing breast cancer, because nobody is preordained to develop breast cancer in their lifetime, despite inherited genetic defects they might have in anti-cancer mechanisms, the best of which are known are the BRCA1 and BRCA2 genes. And these, again, are not preordinations. These are actually defects in anti-cancer mechanisms. And there is a paradoxical foible taking place in current practice, which would indicate that women who are known to have the BRCA1 or BRCA2 genes would start to receive mammograms earlier in their lifetime and receive them more often as a way of picking up breast cancer. But as the column A or the item A indicates here, radiation is the best established cause, environmental cause of breast cancer. So ironically, by starting mammography, which is a potent source of radiation, onto sensitive, vulnerable tissue at earlier ages, you are vastly increasing the likelihood that that woman will develop breast cancer. Now, nutritional deficiencies are also very important to making cells vulnerable to the effects of mutations. Defects in a broad variety of important nutrients will make tissue much more vulnerable to the effects of breast cancer, the sources of mutations. Can I have the next slide, please? Now, breast cancer is unfortunately the most common type of cancer that women face. These are the statistics from the National Cancer Institute for 2011, which is the most current. We've got something in the range of 350,000 women will be diagnosed with breast cancer this year. Breast cancer is also a very lethal form of cancer. It is the second most common cause of cancer deaths. Can I have the next slide, please? Now, breast cancer incidence increases with age, and right now the best indication is that women face a 1 in 8 lifetime likelihood of developing breast cancer. This is greatly increased from what it has been in the past. It is down just a little bit from the peak level of that we saw perhaps in 5 or 8 years ago. But our grandmothers didn't have to deal with this type of a threat. And there's been a major sociologic change that has caused breast cancer to become a much more prominent problem for women overall and younger women in particular. It used to be that if a woman was not yet 50, she virtually had no chance of developing breast cancer. But as the incidence of breast cancer has gone up, it's largely the youngest women who've borne the greatest burden of that. In our own laboratory, our youngest confirmed case of breast cancer is in a girl of 14 years. And while that is unusual, right now, the most common cause of death for women aged 35 to 50 is breast cancer. Could I have the next slide, please? Now, for younger women, being diagnosed with breast cancer is a much greater problem because of something called the doubling time. And that is the time it takes to go from 1 cell to 2 cells to 4 cells to 16, and so forth and so forth. The younger you are, basically the faster breast cancer grows. And generally speaking, breast cancer is considered a fairly slow-growing type of cancer, which should give us a long diagnostic lead. In other words, being able to pick it up years ahead of it becoming a major problem. But it is diagnosing breast cancer is not a particularly easy thing. Could I have the next slide, please? There we go. Now, very important is the notion that because breast cancer is a slowly growing type of cancer generally, it takes more than 15 years from the time of its inception to the time of a person's death. A lot can be done during those 15 years to detect the disease early and intervene to prevent death. Now, the next slide, please. Thank you. Now, there is an imperative to early detection for breast cancer, and in a nutshell, this is it. Detecting breast cancer at stage 1 or 2 provides an individual with a 96% probability of being alive 5 years after that diagnosis. If that diagnosis is made at stage 3 or 4, the odds are less than 40% survival. So that's a big difference. Moreover, detecting the disease early means that just about any treatment option is going to work, and that the woman will have real choices, or should have real choices, in terms of what type of treatment options are going to be applied. And in detecting at the late stages means that every move is a desperate type of measure with very few choices. Could I have the next slide, please? Now, detecting breast cancer is different than diagnosing breast cancer. Detecting breast cancer, there are a variety of imaging tools that we use, as well as physical exam to detect breast cancer. But the diagnosis, in a proper term, is only made really when samples of the suspected cells are given to a pathologist and put through some very specific tests. And that's usually done only through a fine needle biopsy. That's different than what it was so many years ago, where the suspected lump had to be removed entirely. And unfortunately, because the imaging techniques of the past were not very good, this led to a great number of unnecessary biopsies. It still does. Something in the range of 83% of the biopsies that are being done are unnecessary, because the indications of imaging are giving false positive results. Now, when most people think of diagnostic imaging, they think of mammography. Mammography was the first developed means of diagnostic imaging, and it is still the most widely available. But there are other modalities, and the one I'm going to be concentrating on is thermal imaging. MRI is also a viable diagnostic modality, but it is not one that can be used in a screening role because there are potential hazards, not so much from the intense magnetism that's used in that, but more the consequences of a potential reaction to the metal-based dye that is used to contrast and identify the abnormal blood vessels. And it's also involving very expensive equipment and a very time-consuming procedure. The most inexpensive that I've seen for a screening MRI study for breast cancer is in the range of about $2,400. Diagnostic thermal imaging can be done on a mass scale, covering large numbers of women at a very inexpensive rate and with a very high diagnostic sensitivity. Could I have the next slide, please? Now, physical examination was the technique that was, of course, first detected because at some point a tumor tends to grow large enough to where it can be felt. But this is not early detection. Mammography really had its origins in the 1950s, and there are two varieties of note. There's a film method and there's a digital method. Right now, because largely of the failings of film mammography, digital is being offered as a new kid in the block, something new with potentially more sensitivity to it. But the studies have shown that digital mammography doesn't really offer any advantages over film mammography. Now, for thermal imaging, there's two methodologies that are currently available. There's thermography, which is done at a more empirical judgment level, and then there's thermology, which is done at a more scientific level. Ultrasound is also being used to a limited extent in a diagnostic modality for breast cancer. Done as a screening procedure, it has a lot of false positives because there's lots of structures that typically take place in women's breasts, and it's difficult to know which one of those lumps and bumps is a breast cancer and which one is a fibrocyst or a gland or something else. And as I mentioned, magnetic resonance imaging, MRI, is also in a limited extent being used diagnostically or used in a screening modality. And then there's two varieties of that, static and then dynamic or fourth dimensional, which is actually using a computer program to watch the infusion and washout rate of the dye through the blood vessels. Could I have the next slide, please? Now, detecting breast cancer does become very important to considering the size. And this is something that really does direct the judgment as to putting together a program of early detection. Physical exam, unfortunately, and it doesn't matter quite how you're built on this, whether you're a double A cup or a double D cup. You would think theoretically that women would know the structure and texture of their breast better than anybody. But the threshold for self-examination tends to be about something bigger than 4 centimeters. That is not early detection. That is probably stage 3 disease where there's already spread of the disease outside the breast, and saving a person's life at that point becomes a desperate and heroic effort, involving a lot of very aggressive type and most, unfortunately, very unpleasant type of treatment. For nurse practitioners and clinical physicians who palpate breasts day in, day out, their detection level is better. It's about 2 centimeters, but still that is not early detection. This is typically borderline stage 2, stage 3 disease. And there's very little evidence that even clinical examination is making a difference in terms of saving women's life. Certainly, both by self-examination and by clinical examination, lives have been saved. There will be those examples. But as a public health feature, clinical exam as well as self-examination are actually being discouraged these days, especially because women have fibrocystic disease so commonly, and this type of thing becomes easily confused with breast cancer. A lot of women are getting needless procedures as a result of that and being put through a lot of anxiety. Now, the typical threshold for mammography, which is potentially a source of early detection, is about 10 centimeters. That's about 4/10 of an inch in diameter. And usually at that, you're dealing with stage 1 to stage 2 disease, which in theory is early detection. Under the most ideal of circumstances, breast cancer can be found by mammography as small as 5 millimeters in size, and that is generally early detection. But that also means that the cancer has been present for many years ahead of time, and that aggressive treatment has to be implemented very quickly in order to save somebody's life. Now, diagnostic thermal imaging, thermology, is detecting biomarkers of breast cancer that very much exceed the physical size of breast cancer. And the biomarkers really begin at about 1/5 of a millimeter in diameter, which is really early detection. Routinely, we're finding tumors that are smaller than 2 millimeters in diameter. Could I have the next slide, please? This is a routine set of images of a woman using diagnostic thermal imaging. There is no color to infrared, so this palette is one that's added by a computer, and the colors that are used are coded to correspond with what we would psychologically think of as hotter temperatures. So the robin's egg baby blue is the highest temperature, and from there we have the white, yellow, red, magenta, through the light green, dark green, kind of a gray, to finally dark blue and black.
Isn't red mean hot?
Well, yes, it does. That's why it's coded this way. But yellow is most people actually think of as being hotter.
Okay.
And I think in terms of certain types of flames, the light blue is often the hottest type of flame. So psychologically, that's kind of palette is applied to thermal imaging. But when it's being used not in empirical type way, but in a quantitative way, the only benefit of the image or the color for that matter is helping us to identify patterns that we'll go in and do quantitative assessment of. Thermology is different than thermography because it is quantitative and it is objective and uses a different type of methodology. But the notion here with these images is that we can see that this woman has essentially symmetrical distribution of heat patterns taking place in both breasts. And you can see the three typical views to show the sides of the breast as well as the front of the breasts. Could I have the next slide, please? Now, with all that has gone into the development of the current paradigm and the kind of thing that has been held up as the standard of care and the kind of thing that women should rely on for so many years, the question is this standard of care saving lives? That standard of care as it exists right now is self-examination, clinical examination, mammography, and biopsy. Could I have the next slide, please? The cold facts are that this paradigm, through medical care, has not provided an effective early detection for most women. And despite some of the rhetoric that you'll hear from studies, breast cancer mortality, the percentage of women who are being diagnosed who actually die of breast cancer has not changed appreciably in the past 50 years. This is a horrible circumstance, and this is something that nobody should be satisfied with, certainly nothing that somebody should be sanguine about. What we've heard of progress in terms of treating breast cancer has not resulted in anything very effective for the average woman. Can I have the next slide, please? Now, largely relying on mammography as the means of early detection is proven ineffective, and it's proven ineffective for a number of reasons. First off, there's what I think is a very high false negative rate. That means false negative means that you miss breast cancer when it's present. And that occurs under the best of circumstances 20% of the time. For women under 50, because of glandularity and because of density of their breasts, this often hovers around 40%. So really, many times, detecting breast cancer with a mammogram becomes almost as good as tossing a coin. Now, 10 to 15 women develop what are called interval breast cancers. That is, that within a year of their prior mammogram, 10 to 15% of women will have developed breast cancer. So this is not providing an adequate lead time, and it's telling you that breast cancer is missing mammography is missing a great number of breast cancers and providing a false sense of security. Even worse than this is the number of false positives. And mammography, when used alone, has an 83% false positive rate, and that's based on finding that 17% of the biopsies that are done based on positive mammograms are positive for breast cancer. So mammography is increasing the anxiety and the cost, and mammography really is of little value for women under 50. Mammography as a primary diagnostic procedure has not saved lives. Could I have the next slide, please? Now, a few years ago, the public health side of this has begun to look at the benefits and harms associated with breast cancer. And a lot of large-scale studies have been published out of the Scandinavian countries where immaculate record-keeping was accomplished. And basically, in order for one woman to avoid death from breast cancer, approximately 1,000 women will have a false positive study, and 500 women will undergo an unnecessary biopsy. And breast cancer will be overdiagnosed in 5 to 15 women who will be treated needlessly with surgery, radiation, chemotherapy, or a combination. That's a lot of carnage in order to save one person. Can I have the next slide, please? Now, thermal imaging works in a very different principle as does mammography. Mammography is an anatomically based study, whereas diagnostic thermal imaging is functional. It is studying distribution, features, and behavior of body heat. That body heat is a byproduct of metabolism that must be transferred to the environment to keep us all from cooking. Most of that energy, in metabolically derived body energy, is being emitted from the skin in the form of infrared. And the intensity of that infrared energy is proportional to the skin temperature. The blood flow through very small blood vessels is largely what's responsible for skin temperature, and that is very much modulated by the autonomic nervous system. That's a little bit of a science lesson, but hopefully that'll help to understand things as I move along. Could I have the next slide, please? Now, for many years, thermography, and I'm using that word advisedly, was very much a phenomenon where heat patterns were seen and that were associated anecdotally with breast cancer, but nobody understood the relationship, why breast cancer was producing these heat patterns. And this actually limited the deployment of thermography in that stage because the lack of basic science kept things at very much a empirical level, and there were a lot of false positives as a result. But in the past 20 years, maybe 25 years, the scientific basis of thermology has been derived. And that breaks down into two things. Blood vessels, well, breast cancer must develop new blood vessels, and that process is called neoangiogenesis, in order for those cells to be able to amass to form a tumor. And those blood vessels are very different from any normal blood vessel in the body. They have a different structure, and they're not connected to the autonomic nervous system at all. Also, cancerous cells as well as precancerous cells are producing just huge amounts of a simple molecule called nitric oxide. And nitric oxide acts as a very potent dilator of blood vessels. Could I have the next slide, please? These two mechanisms are the most important basis by which we're seeing the heat patterns in the skin. Now, the imaging process is quite simple. While a woman is standing in the range of 2 to 3 meters from the camera, imaging is made of the front and both sides of her chest. Then we ask the lady to immerse both hands into a basin of cool water for a minute, and then we repeat the series of images. There's no radiation in this process at all. There's no breast compression. It's done in a private setting, and it can be done in a large scale at a very low cost. Next slide, please. This is what a normal set of images looks like. The top row are images made before the lady has had her hands into a basin of cool water. At this, what we're looking for is right to left symmetry. We're looking for differences in temperature levels between the right and left side, as well as patterns. You see various lines coming off of some of the hotter features where we're actually doing quantitative measurements. And we're using that particularly in the second set of images along the second row along the bottom, where we're measuring the temperature effects of the cold challenge. And we would like to see that those blood vessels have become cooler as a result of the lady putting her hands in the cool water. That's a normal adaptive response that's not seen when breast cancer is present, because breast cancer, the heat of breast cancer is because of unregulated blood flow. Can I have the next slide, please? Now, in this lady, the pattern on her left, which is on our right, you can see that there is a different distribution of these blood vessels. Those blood vessels are notably hotter than what we're seeing in the right breast. And those blood vessels are not reacting normally to the cold challenge. So this is an abnormal study. And this is providing potentially early detection of breast cancer. Can I have the next slide, please?
Did you do the next slide?
Unfortunately, this is not early detection. This very bright pattern that we're seeing in this lady's left breast is a more advanced breast cancer, and odds are the disease has already begun to spread to different areas of her body. We can see that this is not because of the heat is not because of a rash or some other non-malignant basis, because the pattern did not respond normally to the cold challenge, no matter how hot it is. Could I have the next slide, please? Now, there is a great deal of confirming, supporting research. There have been studies with 58,000 patients. We've had we followed those women for 5 years, women who had atypical studies, and 38% of them had proven breast cancer within 5 years. Those are women who had normal mammograms. 90% of the women with abnormal thermology studies had diagnoses of breast cancer confirmed by biopsy. Next slide, please. Mammography, the effectiveness of mammography, clinical examination, and thermology were compared in one particular study in the detection of breast cancer. This one study demonstrated that thermology had the best reliability, but as what you might expect in the real world, the best results were found when all three methods were combined. Can I have the next slide, please? A study that we did at our own facility on 2,000 patients demonstrated that we had a diagnostic sensitivity of 97.4% and a specificity of 78.4%. Well, that's not perfect, but that's using one modality alone, and this was following these patients for 6 to 7 years. And what this demonstrates is that thermology, because of its high degree of sensitivity, does make for an excellent initial screen for breast cancer. And the specificity is high enough to where it does an abnormal thermology study does warrant follow-up with other diagnostic modalities. Can I have the next slide, please? Contrast that with mammography at about an 80% sensitivity and a 17% specificity. Now, there's been over 800 peer-reviewed studies in the medical literature and a database of well over 300,000 women as study participants. And some of these are very large groups also, up to 85,000 in single studies. And some of these patients have been followed for up to 12 years. So my point out of this is that thermology is not something that's unsubstantiated. There's a lot of evidence for it. And that evidence is well known by the U.S. National Cancer Institute. This is something taken directly from their website. And with beyond a bit of a description as to how it's working, the bottom line here, which I've put in italics, show that that thermology is providing the earliest signs of breast cancer. Can I have the next slide, please? Now, it is very important to screen women under 50 because, as I've indicated, breast cancer is the biggest killer of women aged 35 to 50. And mammography is not even recommended for women under 50 from the U.S. Preventive Services guidelines. For women over 50, thermology is an important adjunct to clinical exams and to mammography, and will identify with that kind of program more than 98% of the breast cancers. Younger women, unfortunately, like in many ways, think that they're bulletproof, and this is an older woman's disease, but breast cancer has long roots to it that begin perhaps even in our childhood in terms of environmental causes. And we really need to begin to screen women at age 25 with thermal imaging. And a good point out of this is that the standard of care of self-examination, clinical examination, mammography really has not worked well. And if you're expecting the standard of care to be modified to the point where it's going to save your life as an individual, well, it's changing that standard of care is like turning a very large ship. And if you wait for it to change, you might miss the boat. What I find most remarkable is that we're not hearing this particular October, get your mammogram. And this is because there have been enough studies now showing that screening mammography is not an effective means of diagnosing breast cancer. It's not doing an effective enough job in indicating the disease at an early enough stage to save people's lives. And there is no more credible basis for mammography as a large-scale screening process. And that comes as a shock, unfortunately, to a lot of people. They're not hearing that type of thing, but it's in the medical literature. And for some of the foundations, like the Susan Komen Foundation, who probably based more on inertia than anything else, have been touting the benefits of mammography, they've been taken to task for this and shown that the statements they were making routinely last year and the year before that and the year before that can't be substantiated any longer, and basically it's making false statements. And this has caused a shakeup at the Susan Komen Foundation, where I think the president and various directors were forced to stand down. And because of that, you are not hearing the solution to breast cancer in this Breast Cancer Awareness Month to be go get your mammogram. And a lot of women are marching around thinking that they're accomplishing something, and while marching around it's probably good exercise. As far as supporting these foundations and their programs to encourage mammography, unfortunately it's not accomplishing very much at all. The source of a solution is not going to be found from these foundations because they're part of the paradigm. Many times they're very invested in it as their source of funds and the people who make up their directors. And it comes down to the individual and her physician as to making the necessary decisions that are going to save her life. And at that, I'd like to open it up for questions. Certainly, Debbie, you've looked this material over. You might have some questions you'd like to throw out.
Yes, I have a lot of personal questions, and also there have been people in the chat. We have a thermology provider, Christy, who is also there talking and asking questions. I wanted to make a statement that in early detection, to me, is a wake-up call, and that with the use of thermology, and am I allowed to call it thermography or a thermoscan, or is this completely different?
Well, one is a subset of another, which is a subset of another.
Okay.
Thermography was the state of the art some 30 years ago, and it really implies more the empirical, non-scientific evaluation of infrared images. And there are still people who are practicing around that, where they, by their experience and their judgment, will look over an image and come to a conclusion as to what they think it is for significance, whether they are finding this as a problem or not. Thermology was derived from thermography, where quantitative, objective, and scientific principles were applied. So that is a subset of thermography. And truthfully, for most applications, what we're doing now, I don't even call it thermography anymore. And Thermoscan is a trademark name of our laboratory. Thermoscan is something that my late father and I founded in June of 1972. I guess it's a very good name, but we've also worked to earn the reputation that goes with that as the most reliable provider of diagnostic imaging for breast cancer in the world.
And people can go onto your website, thermoscan.com, and find
Yes.
a provider in their area. And
Yes, we have a locator there.
wonderful. And to me, with the knowledge that we can gain from a thermology through this scientific procedure, we can learn about potentially the growth of cancer so many years earlier that we might not have to do aggressive techniques or invasive techniques, but cleaning up our lives with what we're putting into our body and what we have in our homes and the way we think, a lot of other techniques. Do you agree with that, or I want to hear your recommendation of what to do after a diagnosis?
Well, ultimately, what's going to determine whether somebody lives or dies with the diagnosis of breast cancer is the integrity of their immune system. Their cellular immune system is critical to hunting down breast cancer cells that may be distributed through their whole body. Studies have been done where women with even early stage disease have been found to have breast cancer cells in their bone marrow quite distantly. And it is the cellular-based immune system that will track those down and kill them. Unfortunately, the cellular immune system is also one of the first casualties of typical cytotoxic chemotherapy. Radiation, while it does a job of killing cancer cells, is also a potent carcinogen for secondary types of cancers, as well as on a larger scale being damaging to the immune system. So a lot of the type of treatment that's being used is providing short-term results and long-term problems.
Okay, so I didn't really, that was really informative, but I guess I'm looking for what we can do proactively.
Well, let me give you a quick story. A close friend of mine was a nutritionist who had cleaned up her act and had what she considered to be an immaculate diet. And she was so convinced that that diet was protecting her from many diseases that when she developed a mass in her breast, she concluded that it couldn't be cancerous. And she only went for testing when that mass became so large as to fill the whole volume of her breast. And of course, the story is not good. It was malignant, and she didn't have a good outcome from this. And so much of what we know about the causes of breast cancer relate back to environmental, and they relate to the thousands of chemicals that we're being exposed to on a daily basis. They relate to casual use of diagnostic X-ray and other sources of radiation that we're being exposed to. So much of that can be avoided. There's so much that can be done through proper nutrition to help our cellular-based immune system to deal with the small cancerous cells that may arise in the body, that cleaning up one's diet and avoiding common carcinogens is critically important. and being able to identify signs of tissue stress through thermal imaging and intervene is a very exciting aspect of what we're doing, because the prospect is there that we're changing fate. People are living that would have been diagnosed with the disease and being at risk of dying otherwise. Is that a better answer?
Yes, and it seems like with this thermology, you can keep an eye on and watch the progress of the disease, since you have some time to act and deal with it, that let's say within a couple of months' time or even a year's time, you can see, for instance, that story of the woman was not a good outcome, but she neglected to do something and maybe was not watching close enough the progression of that illness. I have a question about what about people who have lots of calcifications? They tell me that they go in and get needle biopsies annually for this type of problem. What do you say about that?
Calcifications are not themselves a mechanism of breast cancer. Calcifications are a tissue response to stress, physical stress, many types of stress. And unfortunately, the more biopsies that are done, the more mammograms that stress tissue as well, the more calcifications will occur. Calcifications become one of the most reliable things that a radiologist has when they're looking at a mammogram, but there are still a lot of failings to that. Calcifications may occur for more non-cancer related disease related conditions than because of breast cancer. So calcifications are something that are useful on mammography. There's other kinds of things that we look for with thermology. For the woman who has so many calcifications that it's not offering any particular value any longer in identifying risk for disease in her, thermal imaging would be an ideal adjunct to what she's doing.
Thank you. And what about men who have, let's say, concern about prostate cancer? Is this technique available for men and their potential cancer diseases?
I wish, but no, it's not. The thing is, the prostate is deeper within the body, and that we don't have good means of imaging it from the outside with thermal imaging.
Okay, and Dr. Wakwar on the chat asks, what would red indicate in terms of pathology from the slides that you showed?
The colors themselves don't indicate anything other than possibly connecting up with patterns that might be of interest. We do quantitative measurements. We also look at patterns of blood vessels. Importantly, we look at the behavior of those thermal patterns and the levels through the cold challenge. And we also follow people over time for evolution of these patterns. Some people will have minor unusual features that are just part of their own structure, something that is distinct to them that's not really related to a disease. We call those personal variants. But in this case, you can see that that's up on the screen. There's a large concentration of red pattern taking place in this woman, the cranial aspect of this woman's left breast. And that's indicating a density of higher energy blood vessels in that area. And those would be features of risk for breast cancer.
And Christy says that was a really good question to ask and a good answer. And she also wanted to know, what was the color palette, temperature range, patient history, thermography, compares past images to look for increased localized heat over time. That was you were just talking about the evolution of the disease.
Yeah, I think so.
Were client, and she asks also, were the room and client preparation protocols followed? And that means like really to the T of getting those hands in the ice water for the right amount of time and the coolness of the room to make sure the preparation was correct. I assume that's what she was mentioning.
Well, basically, Thermoscan wrote the book as to what are the standards. Our laboratory standards here are the highest in the world. You can see much of what those preparation standards are if you go to our website, thermoscan.com. Generally, the room temperature is between 68 and 70 degrees, with no more than a degree variance during the time of imaging. We have no radiant light or heat sources in the room. The patient is equilibrated generally for about 10 minutes before we begin making images. There are a lot of subtleties to it. And as I say, we wrote the book on proper imaging protocol.
And lastly, she mentions to comply with IACT, AAT protocols. Christy utilizes the infrared white hot palette. And this sounds kind of technical as to what that is. I don't know whether the folks listening would benefit from any kind of comment.
Most folk wouldn't benefit. This is more of a technical issue, I agree. White hot palette means a gray tone. And for many years we worked with a gray tone palette instead of a color palette. In one way, it is a more honest palette because you find continual gradient changes through that instead of the abrupt changes that are used in color. I worked with black and white for many years with no problem because what we're doing is not based on the simple appearance. The palette is not that important an issue for us. It seems, though, that when we put together images and we send those out to our referring physicians, they like images in color rather than black and white, so that's the way we present them. But our analysis is not based on judgment or an empirical type of evaluation. So it is more quantitative, and for that reason, the palette part is not all that critical.
Okay, in our last 2 minutes of the show,
Yes.
I want to thank you so much from the bottom of my heart for being on here today. This is a critical issue for women today. This
Indeed.
is in participation with Breast Cancer Awareness Month, October 2012. Please, folks out there, share this. This is archived. It's on the Health In Show. Anybody can view it at any time that's convenient to them. And is there any other words that you want to say?
The word that I want to say more than any other is empowerment. And in order to empower women to save their lives, they have to do something that may be stepping out of the routine, the paradigm. That does not assure a good outcome for them. So they have to seek answers, and they have to demand good answers.
And I have a couple quotes. Martha Weinman Lear said, "Women agonize over cancer. We take as a personal threat the lump in every friend's breast." Olivia Newton-John said, "My cancer scare changed my life. I'm grateful for every new healthy day I have. It has helped me prioritize my life." And this is absolutely true. I know people think it's silly. Some people say my cancer was a blessing, but we don't have to have the cancer. The warning signs are there. We can do thermology and know ahead of time, get plenty of time to change our lives and prioritize now, today, do those action steps. I'm so thankful also that you have developed this type of technology and that it is available in, I don't think you mentioned how many countries in the world?
I don't really know how many countries in the world. I went to a meeting in Portugal last month, and we had representatives from 27 different countries. This is certainly not everywhere, and unfortunately there are people who are doing this type of thing who are not doing it very well. So there's not a uniform quality control. One has to be very careful about the providers that a woman would seek for something like this. But if she does her homework, if she makes the commitment that she's going to do something different to have a different outcome than those that she's become aware of, we take a great deal of pride in being that type of resource that you can feel good about for yourself, and you can refer to your friends and relatives.
Thank you. Thank you, Amnon. Fantastic show. Love the slides. Upcoming is going to be Erica Perlow on bullying and activism. She's an attorney at law and will be on next Monday. Then following that is Garla Smith, writing your resume as a healthcare provider or professional. And we have Wednesday of this week on Blog Talk Radio, Dr. Adil, cardiologist, talking about health in every form and manner. On Thursday is Alan Phillips, Vaccinations in Your Right. That's on Thursday at noon on Blog Talk Radio. So sending our love, waves of awareness out to everyone in the Twitter sphere, the internet sphere. We love you. Bye-bye until next time.
You are tuned to the Nissan Communications Network. Our weekly lineup of call-in programs includes Computers 2K Now with Amnon Nissan, Sundays 9 a.m. to noon. Health In with Debby Bruck, Mondays 11 a.m. to noon. The Scope of Things with Marilyn Shannon, Mondays 7 to 8 p.m. Breaking Free with Marilyn Shannon, Mondays 8 to 9 p.m. Body Talk with Cindy Prince, first Tuesdays 8 to 9 p.m. Reawaken Your Brilliance with Julie Seibert, Wednesdays 8 to 9 p.m. And if you tuned in too late, you can always watch each program in its entirety or download an MP3 audio file of it at www.nissancommunications.com. Sponsored by thatvidblasterguy.com, CarolinaApparel.com, and DeltaForce.net.